I'm Stephen Bailey, Editor-in-Chief, Catheterization Cardiovascular Interventions, and I'm joined today by Dr. Alaide Chieffo. And we're going to talk about her recently submitted manuscript that's been selected as Editor's Choice in the March issue, where she tells us about their new approach for vascular closure in TAVR patients. Can you share a little bit about what brought this to you and why you decided that you needed a different approach?
Yes, first of all, thanks to have selected our paper as the paper as the cover paper of the journal. It's a big honor for us, clearly. And the idea came, as always, from our clinical practice in order to try at least to sort it out which are the problems that we are encountering. And in this case, unfortunately, even if in my center we have performed so far almost 500 TAVR, still vascular complications are present, clearly less frequently, but they are still present. And as we know from all the studies that have been published so far, vascular complications impact even on survival of the patient. So it's a big issue that we have to sort it out in order to give more penetration to this technique in a more widespread use. So the problem was that in order to better control what we call the therapeutical vascular access of the TAVR, we have also reported this before, that we actually do the crossover technique. Priorly, we use the contralateral grow in femoral access in order to do a crossover and to guarantee to have a wire in the therapeutic access, so in the superficial femoral artery, that would allow us at the end of the procedure, where we are going to close the access, to inflate a balloon and to have a more clean and safe final closure of the therapeutic access.
So in the United States, where we haven't had that experience, we've gone from surgical cut down, which is where everyone starts, with or without a conduit, and then progressed to percutaneous closure, which is where you have been now for a long time. And what you have done prior to this was to come from the other side, across the bifurcation, placing a balloon, so that you could potentially or routinely inflate the balloon to decompress the vessel to assist you with closure. And so that was a technique that you described previously and that you've been using for some time.
But with this technique, we add some vascular complication on the diagnostic site, not on the therapeutic, but actually on the access site for the crossover. And that's why we started to think if we could develop an alternative diagnostic site approach, and we thought about left radial artery. As you know, artery PCI is almost widespread use in Europe, and so we got some experience in the coronary field with the access, and that's why we thought that the left radial artery access would be, let's say, something to be considered for the crossover technique also in TAVR patient. This is in order to avoid the vascular complication of puncturing the contralateral femoral artery. So that's what was our clinical need and actually where the idea came from.
And the left radial simply because it was easier for you to access?
Yes, and also because of the curve, because clearly it's easy to access from the left radial artery to the descending aorta. So, I mean, for the curve, it is on the descending aorta.
So as opposed to the right, which is more tortuous, more difficult.
More complex, yes. So it can be a choice, clearly also the right, but what we were saying for anatomical reason and for the curve that it has, it's easier to go from left radial artery to the descending aorta.
So one of the teaching points for people that are thinking about this and trying to implement it in their practice is easier from the left.
Yes.
And now you have a choice of I guess, types of balloons, because the size of access that you're going to use for radial access was, what French size were you putting in your radial?
6 French.
So a standard 6 French.
Yes.
Big, I know, for some radialists that were into 4 and 5s, but certainly a standard size in terms, and that will allow certain manufactured balloons to go through a 6 French.
I mean, actually what we use routinely is an 8040 millimeter 6 French compatible balloon. First, clearly we have to get the access on the femoral artery, so we go with a long multipurpose to the therapeutic vascular access to the, let's say normally it's right femoral artery. We leave there, we exchange with V18 guide wire that we leave in the what we call therapeutic, in most of the case, right superficial femoral artery to save the access. And then at the end of the procedure, we go with an over-the-wire balloon, as I was saying, 6 French compatible. And as we did with the regular crossover technique, we inflate the balloon while we are closing, we are using normally Procedural device. So when we are closing the knots of the Procedural device, we inflate the balloon. Then we deflate the balloon. From the over-the-wire balloon, we are able to inject contrast. And so we can see actually the closure device worked well, or if there is still some leaking, we can inflate again the balloon, which is already there, and save the access. Clearly, in case you need, you have a big, I mean, if you have a pseudoaneurysm which is not responding with prolonged balloon inflation, you have to consider to implant a cover stent. That actually is what we do in case of pseudoaneurysm or failure of the Procedural device. In this case, unfortunately, radial artery is not big enough because you need 8 French. And in this case, we do bailout crossover from the contralateral groin. But honestly, with the experience, the percentage of cases where we needed a cover stent or where we needed a different kind of device is going lower with the experience. That's why we feel quite familiar with the radial access as a crossover technique.
Like that certainly uncomplicates the field in the groin for TAVR. It provides safety. You have that V18 wire which works very well for passing devices. And you can use the balloon for decompression, which gives you the best opportunity for getting that pre-closed, closed ProStar knot down there and getting a solid dry closure. So
you can also visualize, which is important, because what we do at the end of the procedure is always to do an angiographic control. Because this patient, you know, if they have a complication, it's important to sort it out during the procedure, not to have the problem to have the patient back to the intensive unit care of the ward with a vascular complication that you were unable to detect.
I think that's a great point, that you can check and be absolutely certain that you've got the result that the patient needs for the safest procedure. Well, congratulations, it's a great tip. I know that those of us who are doing TAVR look forward to adopting that as we're getting more experience and learning from all of the experience that you have had there at your center. Thank you very much.
Thanks to you.